Coming to the glaucomatous changes proper, we divide into three: disc and cup changes, then peripapillary area, that is the area around the papilla or the disc, and coming to the vessel changes, that is vascular changes. So we'll see one by one. So first, optic disc and cup changes. We have optic disc asymmetry, then failure of cup, alterations in cup morphology, neuroretinal rim, and lamina cribrosa. So we will see one by one. So before going to asymmetry, we have to know what is symmetry. So the symmetry in size, shape, and CD ratio. First, coming to the optic disc
Madam,
size.
1 minute, 1 minute. I think there is some air or the fan can be switched off, madam.
Okay.
And your connection, if you can switch off your video, then I think it will be clearer.
Okay.
Till you finish your talk. Yeah.
Okay.
Thank you, madam. Thank you. Please, you can talk now.
So
Slideshow.
I'll switch off my videos, sir.
No, your video from the camera. You have a video on and off, no? There, next to the audio. Mic.
Yes, sir.
Then it will be clearer.
Okay, I stopped my.
Yeah. I'll stop the video. I've stopped it now.
Okay.
You can go ahead. You can go to slide set. Now you can, yeah. Now it's
Okay,
much
sir.
better, madam. Yeah, sorry.
Okay.
Please go ahead.
Okay. So now coming to the optic disc size. So how to estimate the optic disc size? So in the slit lamp, you have a measurement knob which is used to adjust the height of the slit, and the measurement is given in this measurement graticule. So this is the slit lamp graticule where you have measurements from 0 to 14. So first you can use retro illumination, put the slit on the optic disc and adjust the slit up to the vertical part of the disc margin, and then you measure the vertical height. And if you use a 90D lens, you must multiply by using a correction factor of 1.3. So normally we use either 90D or a 78 diopter lens. So if you use a 90 diopter lens, you multiply the optic disc vertical diameter by 1.3 and you note down the vertical diameter. Then you keep a horizontal slit, note down the average horizontal diameter. See, the normal average vertical diameter is 1.8 and horizontal diameter is 1.7. Since the vertical diameter of the optic disc is more than the horizontal diameter, the shape of the optic disc is vertically oval. And one more method that you can use is your direct ophthalmoscope scope. So either you can use a Welsh-Allen scope or any other scope. See, a Welsh-Allen scope means the aperture size will be fixed. It will be a 5-degree aperture. And if you put the 5-degree aperture over the disc, and if the disc margin comes within this circle, it is called a small disc. So the size will be less than 1.5. And if you put the circular aperture and the disc correctly fits in it, it is a average disc or a medium sized disc or normal disc. And suppose if you put the aperture and you see the disc margin outside this aperture, it indicates a large disc. So the large disc more than 2.2 millimeters. Next, come to the neuroretinal rim. So as I told, neuroretinal rim will be more prominent in the superior and inferior quadrants. So what is the neuroretinal rim? It is nothing but the optic nerve tissue which is present in this margin and the cup. So cup is the shallow depression which consists mostly of glial tissue which is present in the center. And this neuroretinal rim consists of the optic nerve fibers. So since the superior and inferior quadrant, the lamina cribrosa, the pores are increased in size, you will have a superior and inferior NRR thickness more than the nasal and temporal quadrant. So first, inferior will be the thickest, followed by superior, followed by nasal, followed by temporal. So this is called Isent rule, and Isent rule will be violated in cases of glaucoma. Then coming to the optic cup shape. So we have seen optic disc will be vertically oval. The cup, as I told here, superior and inferior NRR are thick, nasal and temporal is thin. You have a horizontally oval cup. So the normal shape of the disc is vertically oval, cup is horizontally oval. Next, coming to the CD ratio. So measure the vertical diameter of the cup, measure the vertical diameter of the disc, and calculate the CD ratio, cup disc ratio. So you must
தெரியல
measure both.
பார்க்கறேன்.
So sometimes you can have a small disc, you can have a CD ratio of 0.3. Large disc, you have a CD ratio of 0.5. And 2% of normal population have a CD ratio of 0.7. And this usually runs in other family members also. And always look for the CD ratio in both eyes and you rule out the asymmetry. If there is a difference of CD ratio more than 0.2 between the two eyes, it is more significant of glaucoma. So you can see here, this is a small disc, small cup. So CD ratio is 0.2. This is an average size disc with average size cup. So it's a 0.6. And here you can see a large cup with a large disc with NRF trimming. Here the CD ratio is 0.9. So now we have come to know about the symmetry. So this is the actually right eye and left eye picture of the same person. You can see the size, almost same size, and the shape. You can see the disc is vertically oval, cup is horizontally oval in both eyes, and the CD ratio is almost 0.5 in both eyes. So this is a symmetrical disc and cup. You can see here the optic disc asymmetry. You can see the size of the disc is small here, and here it is a large one. And you can see next one, the shape. You can see the shape of the disc and cup here, both are vertically oval. And you can see the CD ratio, right eye it is about 0.5 and left eye it is nearly 0.7. So this is the first thing you are going to look for in an optic disc. And since there is some flaws like a small disc with small cup, large disc with large cup, we come to another scale that is called the DDLS, that is disc damage likelihood scale, that is the rim disc ratio. So how to calculate the rim disc ratio? First calculate the rim width, then calculate the disc width, then you calculate the rim disc ratio. So how to go up this rim disc ratio? See, this tabular column is given in your Sharper's textbook of glaucoma. See here, they have classified it as a at-risk disc, then glaucoma damage, glaucoma disability. So I have taken for the average size disc. See, it is given for even small size disc, large size disc also. So in an average size disc, at-risk disc means the rim disc ratio is up to 0.1 to 0.19, it is at risk. And glaucoma damage means, see, up to 90 percentage, that is less than 90 degree of the NRR loss, it is indicates glaucoma damage. And more than one half of the NRR damage is there, it indicates a glaucoma disability. Now next, we come to the failure of the cup. So cup, I told, this is a central depression, and this is the neuroretinal rim which is present into the disc and the cup. And in cases of glaucoma, this cupping will be more prominent than the failure. But whereas in non-glaucomatous, there is some neurological conditions, the failure will be more pronounced than the cupping. And cupping, we can classify it as shallow cupping and deep cupping. So what is shallow cupping? Shallow cupping means you can appreciate the cup, but the cupping will be up to the prelaminar region of the optic nerve. Whereas deep cupping means extends beyond the prelaminar region. The cupping is very deep. So one such deep cupping is called bean pot cupping, where the cupping is extending more deeply beyond the lamina cribrosa. And another variant of cupping is called saucerization. Saucers are nothing but shallow plates. So here there will be a shallow cupping, but a little difficult to appreciate. That is, the neuroretinal rim appears normal, and in cases of this cupping, the cupping is present, but the neuroretinal rim color is retained in the inferior quadrant or the temporal quadrant. So that is called tinted halo. Then how to identify this shallow cupping? Please trace the vessel. This is a circumlinear vessel. Circumlinear vessel means that is the vessel which is coming out of the central retinal artery or vein. It comes along the margin of the disc and gets its exit. And you can see in this picture, it appears to be a normal neuroretinal rim and a normal cup. But what happens if you trace the vessels? See, the vessel is coming over here. So where the vessel exits, it is the neuroretinal rim. So this is called shallow cupping or saucerization. So these are some different types of cupping or NRR loss. The first one is the diffuse NRR loss leading to the concentric cupping. That is a diffuse loss of NRR. The next one is localized NRR loss. That is a neuroretinal limb loss can produce a notching. That is called unipolar notching if it occurs in one quadrant, and bipolar notching if it occurs in two quadrants. And combination of concentric cupping and notching in the same disc, it is called vertical extension. And next is we have one more finding in the optic nerve, that is called acquired pit of the optic nerve or pseudo pit. That is a sharp localized deepening of the tissue which is located at the outer edge, which is due to the focal laminar insufficiency. And this should be differentiated from notching. Notching means it is a gradual erosion from the center to the outer edge of the disc. So as I told, neuroretinal rim loss we have discussed also in cupping. So it can be a diffuse NRR loss or focal NRR loss leading to notching. Then coming to lamina cribrosa. So lamina cribrosa, we have some pores through which the optic nerve is going to pass through. And when the retinal ganglion cells are getting dropped out, this laminar dots will be seen very clearly. So that is called laminar dot sign. And in advanced stages, these laminar dots are more prominent in the superior and inferior quadrants, giving a appearance of hourglass. So we have completed the disc changes. Coming to the vascular changes. See, the main principle is of the vascular changes is normally in normal persons, you can see the optic through the optic nerve, the central retinal artery and vein comes, and in the optic nerve it divides into superior, inferior, for the nasal and temporal branches. But what happens when there is a cupping? It go along the cup, okay, and takes sharp angulations, or it hangs on the laws of the neuroretinal rim. So we will see one by one: nasalization, biometric, BCLV or bearing of circumlinear vessels, overpassing of vessels, and disc hemorrhages. So normally the vessels, when it comes out of the cup, it slightly goes on the nasal side and then divides into superior and inferior quadrants. But here when there is a neuroretinal rim loss, there is an extreme nasalization of the vessels. But it is non-specific for glaucoma. And coming to the second find, that is the bayoneting. So what is a bayonet? Bayonet means this is a instrument which is attached to the rifle, which has double angulation. Similarly, in glaucoma, you can see double angulation of the vessels. When there is a neuroretinal rim thinning, there will be sharpening of this edge of the optic disc. So there you can see the vessels while coming out, it takes an angle at the neuroretinal rim, and at the exit it takes another bend. So there is a double angulation due to the sharpened rim. And what is bearing of circumlinear vessels? The circumlinear vessels, while coming out, due to the neuroretinal limb loss, there will be a space created between the optic disc and the circumlinear vessel. So that is called bearing of circumlinear vessels. The next, overpassing. Overpassing means the vessel, while coming out, due to the extreme NRR thinning, it appears to bridge the cup. That is, it is floating over the cup. That is called overpassing of vessels. Then disc hemorrhage. So disc hemorrhage is one very important finding. We should be very cautious if present. It consists of a papillary region as well as a peripapillary region. If the disc hemorrhage is present, always follow up the patients for RNFL loss and notching. So that is a very important triad we should remember in mind: hemorrhage, notching, RNFL loss. Next, coming to the peripapillary area changes, we have alpha zone, beta zone, and RNFL. So we'll see one by one. First one is the alpha zone and beta zone. So we all know the Elkschnick ring marks the boundary of the optic disc. And outside this optic disc, there will be a hypopigmented layer through which the choroidal vessels can be seen. So that is the beta zone. And outside the beta zone, we have a hypopigmented layer, which is less significant, that is called alpha zone. It can be present in normal individuals also. So a word about beta zone. See, the beta zone is very large, and if it is very pigmented or hyperpigmented, and it is related to the thickness of the rim. So the rim rim thickness is inversely proportional to the size of the beta zone. If the beta zone is thicker, then the neuroretinal rim loss is more. Then coming to the retinal nerve fiber layer, so you got shortly on anatomy. So you can see here the superior arcuate fibers from the temporal half goes and gets inserted into the superior and supratemporal part of the disc, and inferior arcuate fibers getting inserted to the inferior and infratemporal part of the disc, and papillomacular bundle fibers getting inserted into the temporal half of the disc, and nasally superior radiating fibers gets inserted into the superior and supranasal half of the disc, and inferior radiating fibers getting inserted into the inferior and infranasal part of the disc. And how to identify all these retinal nerve fiber layers? So you can see a silvery striations over the retina. This silvery striations or stripes, this is the retinal nerve fiber layer, which can be best appreciated on the red-free filter. And this, what is the normal pattern of this RNFL distribution? It will be silvery color over the superior and inferior part of the disc, and near the macula it will be darker, and it gives a slightly blurred appearance to the underlying retinal vessels. And how to identify this RNFL loss? So it can be a slit or wedge-shaped defect. You can see between the arrow marks, you can see some defect in the form of wedge. So this is called RNFL loss. So this RNFL loss, you can see, as I told, the vessels will be very much appreciated in this RNFL loss compared to the normal one. So normal RNFL, the vessel usually appears somewhat blurred, but in RNFL loss, it appears very much clearer. And you can see it is best seen with the red-free filter in the final picture. And with all these findings, we classify it as a weak indicator, medium indicator, and strong indicator. So weak indicators are large CD ratio, laminar dot sign, nasalization, and peripapillary atrophy of alpha zone. And moderate indicators, cupping is more than payload, CD asymmetry, violation of Essent rule, bearing of circumlinear vessels, bayoneting of vessels. And the strong indicators, as I told, please remember the triad of disc hemorrhage, RNFL loss, notching, and NRR thinning. So, with this, when you see a disc in a patient of glaucoma, always remember
என்னடி
all
மூஞ்சி
these
எப்ப
things.
பாரு
So
இப்படியே
the
வச்சுக்கிற
5 R's. So the first one is the spiral
என்னத்த
ring of
என்னத்த தேடிக்கிட்டு
Elchnik.
இருக்க
So with this, you are going to find out the optic disc asymmetry in size, shape, and CD ratio. And next one is neuroretinal rim. Always look for the superior, inferior nerve thinning and violation of the isn't true. And third one is retinal nerve fiber layer. Look for the RNFL loss, and using the red free filter, please see whether the vessels
படிச்சிட்டு
appears
இருக்கேன்
any prominent and whether there is any wedge defect. Then look for hemorrhages, and
படிச்சிட்டு
finally
இருக்கேன்
look for the region of beta zone of the peripapillary atrophy. So remember these 5 odds when you look for the optic disc in glaucoma. So now we have seen everything in glaucoma, and also we must know how to rule out other causes of glaucoma. So you can see this patient is having a glistening glial tissue, and these patients usually have associated retinochoroidal colobomas. So this is an optic nerve coloboma. And second important differential diagnosis, you have a grayish pit, okay, grayish pit, and these patients will be associated with the serous detachment. Okay, so this is the congenital optic disc pit. And third important differential diagnosis is this is a bilateral condition. You can see the nasal part of the disc is hyperemic, and the temporal half of the disc is it appears pallid, and there is a temporal crescent, and these patients are associated with myopia and astigmatism. This is a tilted disc. And the next important DD is this, you all know, this is a glial tissue filled with disc filled with glial tissue, and you can see the exit of vessels from the disc, and there is a surrounding annulus of subretinal tissue. You can see that is a morning glory anomaly of the disc. And this, you all know, this is a pallid disc edema. No cupping is present, and it is a frank AON. Then next, this is the optic disc failure, usually seen in children, mostly hereditary. Blue-yellow disc chromatopsia will be seen. So this is a hereditary or hereditofamilial optic atrophy. So So these are some different types of disc which you see in a primary open angle glaucoma or normotensive glaucoma. So first one you can see that is a concentric cupping. So you can see a concentric NRR loss which is usually associated with superior inferior scotomas. And second one you can see a somewhat tilted disc usually associated with myopia, and inferior scotomas are more common, and in young males it can be seen that's a myopic disc. And third one you can see a moth-eaten appearance of the disc. And there are some pigmentary changes, and there's a shallow cupping, which indicates the senile sclerotic disc. And fourth one, you can see that the arrow marks, there is notching. So this is a sectoral RNFL loss, and there is a notching. And these patients are usually associated with some hypertension, and fixation defects will be present. This is called focal ischemic disc, which is more commonly seen in a normotensive glaucoma patients. And in this patient, you can see the pallor is more than cupping. And there is a study recently which is showing that the primary angle glaucoma patients, especially congestive attacks, they have this cupping less than the pallor. That is, pallor will be more than the cupping in case of primary angle closure glaucomas. And a word on cupping in infants. See, cupping in infants is usually reversible. Why? Because there is a lack of collagenous tissue in the lamina creplosa, thin posterior sclera, and the increase in the diameter of the scleral canal with increased IOP. So what happens in infants? Earlier the cupping occurs, later the glial tissue loss occurs, whereas in adults there is early loss of glial tissue, early loss of NRR, and finally there is a cupping, and finally there is a visual field loss. And examination of optic nerve glaucoma, we all know there's a direct ophthalmoscopy, slit lamp biomicroscopy, stereophotography, and OCT, HRT, and GTX. And let me tell a word on OCT alone, because because you people come across this OCT commonly. So we know there are three changes mainly occurring in the glaucoma: optic nerve head, RNFL, and this macula. See, RNFL, you know, we discussed there's the RNFL analysis we are doing, and ONH also optic nerve head changes. We are doing ONH analysis. Why macular analysis? See, here we have four ganglion cell thickness. We have four cell ganglion cells. We have, okay, that is the ganglion cell layer is very thick at this macula. So we do a macular analysis. So RNFL analysis, that is the machine uses a 3.4 millimeter diameter circle around the RNFL, and in this circle it takes 256 A scans in this circle. Okay, each point. So it takes 256 scans, and 400 A scans per second is taken. And macular analysis, and you have a macular cube. Okay, this macular cube will be centered on the fovea, and you take 512 A scans on 128 rows, or 200 cross 200 grid is placed. Then ONH analysis, you place a 6 linear scans in a spokes pattern of 30-degree interval. So we use reference plane dependent mode, we use reference plane independent modes. Usually, what is this reference plane means? This is the retinal pigment epithelium you commonly see in the OCT. So connecting this point gives the optic disc margin, and above 150 microns from the optic disc margin is marked as the optic cup. So this is actually followed in all our OCTs, and in the recent OCTs, actually, we take this reference plane independent, that is Bruch's membrane opening and minimal rim width. Minimal rim width is the distance between this cup area margin and the border marked under this Bruch's membrane opening. So that is called BMO MRW. So this is followed especially for difficult disc like myopic disc or tilted disc, where there will be a difficulty in establishing the OCT findings. So we will see just two pictures and we will close the session. And first one is the ONH radial scan. So first of all, when you take a glaucoma OCT, what you are going to see is the RNFL thickness map. So RNFL thickness map, how to check it? So in hotter colors means the RNFL is thick, at its best. So it will be in the form of a butterfly shape or a hourglass. And usually this hot colors means the RNFL thickness is normal. And if it is cool colors, blue color or green color is seen here means it is thin. And next is one is the RNFL deviation map. RNFL deviation map means you are comparing this RNFL thickness of the patient to the age matched controls in the OCT machine. And the machine is giving this deviation map. This deviation map, if hot colors are present, it indicates it's a abnormal. Red color or yellow color is present if it is abnormal. So it is opposite to the thickness map in color coding. And next one we have a extracted horizontal and vertical tomogram, which is nothing but a B scan to identify the reference plane. Okay, so already I told reference plane, that is the optic disc and optic cup will be marked, and this is the B scan which gives the picture. And next, coming to the circular tomogram. Circular tomogram is nothing but it is the circular analysis of the optic disc, okay, in segmentation. That is, if the layers here present here in the circular scan or normal means, you can identify whether the ONH is reliable, this ONH analysis is reliable or not. And there is one more method of establishing this ONH reliability, that is called signal strength. So signal strength will be mentioned in the top of the OCT form printout, and if the signal strength is more than 6, it indicates it is a good quality OCT. And now coming to the neuroretinal rim thickness. So neuroretinal rim thickness, so this is the Tisnet graph, that is temporal, superior, nasal, inferior and temporal parts are assessed, and this solid line is the right eye and this is the left eye. So how to interpret this? See, a very simple way is green is the normal value. Yellow means borderline glaucoma. Red means there is a severe NRR loss. So we all know the superior and inferior NRR will be thickest. So there will be a double hump, superior and inferior. So in neuroretinal rim thickness as well as the RNFL thickness, you will see a double hump pattern. And next coming here, this is a sectoral analysis, that is the superior optic disc, inferior optic disc, nasal and temporal. This is analyzed. Usually the values will be between 75 to 107. And this is the clock hour analysis of the optic disc. So again, if you need not know the values, just to know the color coding. Green means normal, yellow means borderline, and red means it indicates there is a RNFL loss. And finally, coming to the parameters, average RNFL thickness I told between 75 to 107. RNFL symmetry should be between 75 to 100 percentage, and rim area already it is mentioned is normal between 1.2 to 1.6. Then this area, then you have a CD ratio and cup volume. And now we coming to the last one, that is the macular scan. So macular scan, I told, see, other areas the retinal ganglion cell will be one cell thick, but in the macula, the retinal ganglion cell will be 4-layer thickness. So what happens in glaucoma? There is a ganglion cell loss. So we are here identifying the earlier defects in the macular scan. So this is the macular thickness map. So again here, hot colors means it indicates the thickness. And now coming to the deviation map. Deviation map means you are comparing the macular thickness of the patient with the age-matched control in the machine. And here hotter colors means there is some thinning. Okay, so this is opposite to the thickness map in the color coding. So correspondingly, you can see the sectoral map. There is red color coding, so there is thinning of the ganglion cells. And in this eye also there is thinning. And you can see the average GCL and IPL thickness. GCL means ganglion cell layer, IPLs mean inner plexiform layer. See, the ganglion cell complex is made up of ganglion cells, inner plexiform layer, and the nerve fiber layer. So that is how the thickness is calculated. And this is the horizontal B scan. The horizontal B scan is done to assess whether the segmentation is done in the proper way as like the signal strength. So these are the methods, these are the basic techniques by which you have to check the OCT. Okay, so We must know how to examine, and you must know how to differentiate from other causes of this optic disc failure. And finally, you must know how to interpret this OCT disc. And thank you so much for your patient hearing.
Thank you, madam. It was one of the most descriptive and you can stop slide share.
Okay, sir.
Very informative and although I think we have a mix of practitioners and we have